What we will do today is we'll spend a few minutes going through some information about us, about the program that we offer and the industry and what's causing some of these challenges and how our portal fits those and solves those challenges. And then we'll do an actual demonstration of the solution that we're going to be looking at to show you how it fits. Now, a couple of caveats in this demonstration. Normally, we work in a one-on-one environment with our prospective partner clients, and in that one-on-one environment, we learn quite a bit and ask a lot of questions about what you do specifically. So, for instance, what your patient mix is, how you handle pre-service eligibility, pre-adjudication, collection of money, what information you mine from those activities, how long it takes to collect money, what your staffing abilities are, what your checkout points are like. And based on that information, we then customize the portal and recommend best practices based on your specific needs and abilities. We don't have that advantage in an open demonstration like this, so I want to warn you that a hospital may very well use us much differently than a clinic. An urgent care will use us differently, and even in a hospital environment, inpatient would be treated differently than the ED department or your labs or your imaging centers. So you have to have an open mind, and when we talk one-on-one, we will go through conversation about best practices for each area or for your unique operating procedures. Medical Pay Solutions is a national company. We are a revenue cycle management company. And inside of revenue cycle, we concentrate on the balances that we ask patients to pay directly. Now, we call this self-pay. Many providers still consider self-pay uninsured, so I want to be clear that when we mention self-pay, it is any dollar you are asking the patient to pay directly, whether that be copay, deductible, or co-insurance. We concentrate on this area, and it's the only thing we do. We don't sell medical devices or EMRs or pharmaceuticals. We simply work into this one specific area, and we believe we have become very knowledgeable in it as much as the industry allows, what's going on in the industry and what's happening in the practices in the hospitals, labs, imaging centers, and all of the types of clients we work with. And we work with all size groups, from the multi-billion-dollar hospital groups and large clinical networks to the national surgery centers to the sole practitioner running a single man or woman operation. We also work across all specialties, including dental and chiropractic, and down to every specialty that's in the facility. If you have to file a payer claim and bill a patient, we are a fit for you. Everything we talk about is how to get our money either collected or arranged to be collected in an automated format pre-adjudication at point of care of the first encounter or when you're scheduling the preset appointment. Now, if used properly, we will bring you two major benefits. The first of these is the reduction in losses associated with the out-of-pocket direct-to-patient billing or self-pay. We should reduce these losses by as much as 90%. Now, folks, this should be a major concern to you, especially today, because out-of-pocket as of January 1st has grown to over 30 to 40% of a typical healthcare provider gross revenue in the United States. In addition to that, 49.3% of that money goes uncollected as an industry, as an average in the industry. Now, that's according to the McKinsey report, and you may be doing a little better than that. We find that the hospital environment is actually doing a little higher than that because the ED departments bleed cash, whereas a sole practitioner in a rural town may be experiencing 20 or 30%. But the national average is almost 50 cents of every dollar we bill to patients goes uncollected, and at the very least, even our good pay patients are taking an average of 3.3 statements to pay us, and there are hard costs that we're writing off associated with just the process. Which brings me to the second benefit, and that is the reduction in the hard costs of cyclical billing. Now, we know from statistics and conversations the average cost to send a single statement in today's market exceeds $12. Now, believe me, when I do one-on-one conversations and consultations with groups, I see the eyes roll in the back of the head, and I understand everybody thinks there's no way that we're spending that much money to send out a statement. Well, it's not my statistic. It is a HFMA, MGMA collaborated survey that came up with this number, and let me tell you why. It's not just the paper, the ink, the postage, the envelope, and the wear and tear on your machines. The real cost of sending a statement is your labor cost. Your labor to arrange a payment arrangement, to post the payment when it comes in, and to process the paper check deposit. But that's just the small part. The real cost starts when you get 30 or 40% of your patients who don't understand their bill and call your billing office or your front desk and take a 20 or 30-minute phone call to explain why they owe money even though they have insurance and they shouldn't owe anything. And then, of course, when you institute internal collection, you're paying the person to make those 5 or 10 phone calls or multiple layers of letters, and then you're paying a supervisor or manager to manage all of those processes. If you take all of those costs and aggregate them over the number of statements you send out on a monthly basis, you'll get a true cost per statement for your particular facility, and invariably you'll be shocked or surprised unless you've already done that analysis. Now, we bring you these two benefits, the reduction in losses on patient pay and the reduction in hard costs of cyclical billing, with three basic elements within our tool. The first of these is an instant insurance eligibility. Now, when we say instant, it's 5 seconds to 15 seconds. It's not the standard 20-minute phone call to the insurance company or a 5 or 10-minute visit on a website. But we do more than just tell you if it is an eligible policy. In that same time frame, we're going to give you the copay, the remaining balance on deductible and out-of-pocket for both individual and family in real time, and what that patient is going to owe based on the actual procedures you perform or are scheduling to perform, all the way down to the CPT, DRG, HCPC, or J codes that we create for you. So you'll know exactly what that patient is going to owe either before they see the clinician or before they leave your office from the first encounter. And then the second element comes into play, and that's the ability with the click of a button to print a mock EOB or line item statement. Now, we print these and hand them to the patient so that it makes it easy to move to the next level, which is by far the true power and the true purpose of our portal, and that is the ability to either collect all of that money at point of care or to arrange payments into a pre-authorized and automated format on a credit card, a debit card, a checking, or a savings account. Now, this is what that looks like in real-world perspective. You'd run the eligibility, establish the balance, print the mock EOB, hand it to the patient, and you would say something, and we will teach your people to do this, as simple as, Ms. Smith, the insurance company is going to pay $800. You're going to owe $400. How do you want to handle that today? Ms. Smith will say, either I can pay it all at once, take the check or the money, and be a very happy healthcare provider, or she's going to say, I can't afford that today. Then your staff will be trained to say, that's fine based on your policies. Can you afford to pay $100 a month, and can you pay the first one today? She will say yes, and within 30 seconds to a minute, you will collect that $100, and the system will automatically schedule to collect the subsequent remaining 3 payments, and the money will simply just appear in your bank account. It will eliminate the need to send out statements or invoices, the need to deal with confusion calls, or to start internal collection activity. You will simply just get paid. If utilized properly, we have over 550 facility clients Some of them may have multiple locations, and over 15,000 providers using this portal. And across that spectrum of clients, the average return is we add an additional net cash for our client of $100,000 per doctor, per practice, per year, and this is an average. So there's a variable built into this. One of them is the proficiency with which your people ask for the money and use the portal, and the other is the volume. A hospital is going to realize substantially more than a clinic because of so many departments and so much challenge in the ED. A cardiologist who does $3 million of gross revenue is certainly going to get a better return than a GP who does $600,000. So this $100,000 is an average across the spectrum of client base that we already have. Now, I just want to spend a few minutes on why we are having this conversation and why you are having so much trouble collecting more of the money the patient owes us. First of all, the fact that it has grown to 34 to 40% of our gross revenue, it has exacerbated the problem. The average increase in accounts receivable last year for a healthcare provider was more than 10%. Subsequently, the average bad debt or uncollected also grew by 10% because we're asking the patient to pay so much more money. But the problem is not something you are doing or your people are doing. The problem is the billing system itself. It's broken. It's designed to bill post-adjudication, and it was designed by, for, and to the benefit of the insurance companies 50 or 60 years ago. And quite honestly, it was probably the right plan then, because 99% of our money came from either a commercial reimbursement or a government reimbursement, and only about 1% was coming from patients. Most plans back then were either PPOs or HMOs. By 2001, the number had grown to about 10% of our money was coming from patients, and believe me, 50% wasn't paying then, but nobody cared because we were still getting 95% of our money. Our world turned upside down in 2003 when the government changed the rules on HDHPs and CDHPs. By 2009, and by the way, they changed the rules to keep the premium costs down because costs were skyrocketing, and quite honestly, it worked for about 2 years. Then it stopped working. And by 2009, the average out-of-pocket was 25% of our gross revenue. It had nearly tripled solely because of the introduction and change in the rules on CDHPs and HDHPs. Healthcare reform exacerbated that with the effect of raising premiums last year between 20 and 25% average across the country, and there's a reason for that, i.e. we have children till age 26 on our family plans now. High-risk pools with pre-existing conditions were created in September. Maximum benefits disappeared. More and more employers and self-insureds pushed into high deductibles to the point now where the latest statistic says 1 out of every 2 commercial plans in the marketplace today is considered a high deductible or CDHP. Now, I want to put this in perspective for you. Everything you do post-adjudication is going to cost you more money and have marginal effect. I want you to think of it this way. You don't do diagnostics the same way you did 50 years ago. You don't do surgery the same way you did 50 years ago. You don't take your car in for service the same way you did 50 years ago. You don't even talk on a telephone, especially a cell phone, the same way you did 50 years ago. Yet we keep trying to retrofit a billing system that was designed to bill insurance companies to handle the dollars and the volume of patients using a system that's 50 years old. It just will not work. And by the way, healthcare is the only product or industry where you can walk in, buy a product, leave without knowing what you owe, and sometime 45 or 60 days later, someone's going to send you a bill. Not only one person, most likely you'll get a bill from a primary care, from a lab, from an image center, from an outpatient, from a hospital, from a specialist, And most patients never even open that first bill because they know another one's coming, and then they don't pay anybody until the squeaky wheel starts calling them or sending them reminder letters. It's just a broken system, and it's anything you do to try and work within this system is not going to solve the problem. You may get marginal results, but if you look at the cost to get them, it may not be worth the effort that you've put in. In conversations with literally thousands of providers over the last 2 years, we've been able to ascertain there are two primary reasons we are either slow to get paid or don't get paid at all. The first of these is the patient has to agree they owe the money. And the time you want them to agree they owe the money is at the point of care or at checkout of the first encounter. There are numerous statistical reports on your association websites that tell you even 30 days after care, there's an 84% chance of failure to get paid. 30 days after care. Once you've treated them and they're healthy, you're the last person they worry about paying unless they need you again. So our portal will solve this problem for you. The second is a much more complex challenge. For 60 years, we have been training patients that it's okay not to pay their healthcare provider. In fact, we reward them. Now, I'm not crazy, so let me explain. If you are a patient and you don't pay, doctors are notorious for carrying receivables for 6 months, a year. Some of them we run into have had the same debt on the books for 2 years with no penalty to the patient, and in the hopes that someday that patient will come back and use me and I'll collect my money. Well, that means if I don't pay you, you've basically rewarded me. I don't have to pay you until I need you again if I decide to pay you at all. The second way we reward them, doctors are notorious again for writing down balances. You'll have somebody from the billing office call a 90-day or older account and tell them, look, you owe us $1,000. If you can write me a check for $500, I'll write off the remaining balance. Again, rewarding the patient for slow pay or no pay. And of course, patients have been trained that collection agencies in this vertical are restricted by law about what they can or cannot do to collect a medical debt. That's why the national recovery rate for a collection agency in medical is 15.77%, roughly 16%. So if I'm a patient who doesn't care about my credit score, I know if I wait till you send me to until you send me to collections, I'm probably going to save 84 cents on the dollar and pay you 16 cents on the dollar. So here's the reality of this. We can't allow them to have control of when and how they pay us. We have to have that control. To put it in perspective for you, this patient that came in that had insurance, you don't trust them to file the payer claim and get you reimbursed. You don't trust them to pay you 100% of the money up front and go get reimbursed themselves. You don't do that even though you're not part of the contract between that patient and that payer. You process the claim because it's the only way you're going to get reimbursed in a timely way and know that that claim gets processed properly, hopefully more times than not. In other words, you can't trust them to do this. But then you trust that very same patient to pay you when you send a statement out when and if they feel like it. It just doesn't work, folks, and you know it, you're experiencing it, you see it every day. Just a quick review of some things that are happening in the industry that have got us to where we are, and then a quick review on what healthcare reform is going to do to you that no one has thought of. The first three items on this slide, I've put in here to paint a picture for you. If we agree, and again, it's not my statistical data, that it takes 3.3 statements before a good pay patient, which is a minority in most of our facilities, pays us, that almost 50 cents on every dollar goes uncollected, and it costs at least $10 to send a statement. I want you to understand what this means even in your good pay environment. If you have a balance of $200 and you have to send 3 statements at $10 a piece to collect it, you have spent $30 or roughly 15% of that balance which is gone. It's hard cost. It's written off. Now, the reality is most patients take 5 or 6. So if it takes 6 statements to collect that money, you've now written off 30% of that valid account receivable balance in hard cost. And then it gets really bad for us because now you make a decision to send them to collections. The collection agency gets its national average of 16% collected. You will collect $32 out of a $200 balance, and you will have spent $60 to collect it. And don't forget that collection agency is going to take a third of that. So you'll net $20, will have spent $60, have lost $40, plus never collected your $200. It's just a broken billing system. Our economic environment, 1% of unemployment adds 1.1 million either uninsured, underinsured, self-insured, or Medicaid patients. Any one of those is bad for us either in getting paid on time, at all, or the correct reimbursement. The next one is the one that has scared us the most. Last year, 20% of businesses have announced that they are going to eliminate health care benefits altogether within 5 years, so within the next 4. But it got worse about 6 months ago. You all saw the press about how AT&T and Boeing and Caterpillar were looking at the matrix to see if it was better to pay the $2,000 per employee fine under healthcare reform than to provide benefits. AT&T alone calculated it would cost them $200 million in fines, and it cost them $1.3 billion in benefits. If you were making that financial decision from a business perspective, what would you make? And let me even make that hit home more for you. Monday, I talked to the CFO of a hospital who is doing exactly this. He's going to give his people a small raise. He's going to eliminate health care benefits, and he's going to save $5 million a year in costs and make them buy their own insurance. And he's in the industry that's going to be affected by that. And what it means to you is it's realistic to expect 2 or 3 out of every 5 patients you're treating today that are insured through their employer are either going to be uninsured, underinsured, self-insured, or on a public option, again, making it difficult to get paid on time, at all, or the correct reimbursement. Now, the cost that we spend to collect our AR, 15 cents of every AR dollar goes to collect that dollar as an industry, and 2 cents is what other industries spend to collect that same AR dollar. I'm going to talk about healthcare reform in a second. We've already talked about the CDHPs and the HDHPs. The real issue we have with healthcare reform is not necessarily the fact that it's raising the out-of-pocket with the things that have already happened. We're concerned about what it's going to do to our ability to perform as healthcare providers in a profitable manner from this perspective. The insurance companies have already announced they're not going to wait till 2014 and roll in 30 million to 50 million uninsured patients. You already see the high-risk pools created in most states and people already being added to them. They've announced they're going to start rolling them in 2011, and you're probably already seeing it. Now, this means you're going to see an increase in patient population from anywhere from 10 to 20% each year for the next several years. Now, on the surface, that may sound great. I'll add more patients, grow my practice, create more revenue. But you have to remember who these patients are. First of all, they weren't insured, so they weren't coming in for routine or maintenance care. They couldn't afford a monthly premium of $400 to $800 a month, and they're all going to be lumped into a high deductible or CDHP plan. Therefore, you're going to be asked to collect what amounts to 1 to 5 months of premiums from them when they couldn't afford to pay it before. And the insurance company won't reimburse penny one until all of that deductible is met. Meaning you want to know who's going to pay for health care, it's going to be on the backs of the providers chasing patients who don't have the ability to pay. Now, what does that mean to you really? Okay, if you see 100 patients a day, and let's say the low end you increase patient population by 10%. That's 200 more patients per month, 200 more cyclical billing setup. 200 more payer claim processes, 200 more confusion calls of 20 or 30 minutes. Believe me, they didn't have insurance. They're going to have questions, and 200 more collection activities that you're going to have to institute, all done with the same amount of staff that you have now, with that's already overworked, overburdened, and barely keeping up. And you're going to find 2011, as a result of the increase in high deductibles and the increase in patient population, can either be the worst cash flow year you've ever had, or it can be the best if you can identify what they're going to owe and arrange to get this money secured in a pre-authorized and automated payment that's going to pay. Now, our portal will handle all of this. We're not new to this. As I mentioned, we have over 550 clients and 15,000 healthcare providers using this tool. This is just a small sampling of the various specialties and groups. We have a couple of the larger hospital organizations that you would recognize have national footprints, and we have a little bit different philosophy of how we do business with our clients. Yes, we're a technology, but we're not a technology company. We're a consulting company. We're a revenue cycle management consulting company. So we believe our relationship begins once you are a client. We take the portal and we customize it with your payers, your providers, your locations, your contracted rates, your charge masters, and then we assign a customer care manager who works specifically with and for you to get you the value we promised. They will train your people. They'll provide you all the tools for ongoing training. They'll support you in every way. They'll train your managers to read the reporting and learn what the reporting tells them until you are getting that value. Now, we ensure this is happening because we send out a survey on a regular basis to our client base asking them to grade us. And if I don't see excellence on these surveys, I go back to the customer care person and say, hey, we have an issue here and you need to resolve it. Just to give you an example, this is a CFO of a hospital client of ours who was communicating with a colleague, another CFO, who was looking at our solution, who approached him because they knew each other and asked what he thought. He copied us the email he sent to his colleague, and this is a quote from that email. I'm very pleased with Revenue Maximizer. Medical pay solutions will kill you with customer service. I have never experienced anything like it anywhere. We want to see this from all of our clients, including you, when you become a client. We have, of course, all the referrals and testimonials as needed. And you don't have to take my word for any of the statistical information I have quoted you. It has been in the press. It has been in your local and national association newsletters and websites. Everything came from either the HFMA, the MGMA, the AHA, the AMA, PricewaterhouseCoopers, Anderson Consulting, Salent Group, or McKinsey. And it's there for you to verify. But you don't have to. You're living it. You've seen the first quarter of your reimbursements this year go down substantially. You've seen the money you have to collect from patients this first quarter go up substantially. So the reason it's happening is it is no longer an item that you can put on your wish list. You need to resolve this in a way that works with the least amount of intrusion, the most effectiveness and efficiency, and the ability to get this money collected. And I'm sure you recognize that, which is why you're sitting here on this demonstration. Now I'm going to go into the portal, and again, I want to remind you, we are not license driven, we're transactionally fee based. We make money if you're making more money. Now, because we're not license driven, you can have 1 or 1,000 users. It doesn't matter to us, and we recommend you have as many as you need. The portal is HIPAA compliant, and it's PCI DSS level 1 compliant, which means it's the most secure financial servers in the world. None of the financial information of your patients is ever stored on your local computers or servers, and none of your staff ever has access to the full financial information of any of your patients. This meets much of your red flag certification and compliance and may save you tens of thousands of dollars of redefining how you handle patient financial information. Now, once you log into the portal, it opens up to a tool we call the Daily Dashboard. Quite honestly, this is a management tool. It's simply something that is a snapshot of the financial activity from multiple looks going on within your system. It won't be your frontline people who are interested in it. It's more for your C-level and supervisory people. At the top of this taskbar, you see there are 4 tabs: eligibility, payments, reports, and administration. Your frontline people will use eligibility and payments, and your management and C-level people will use reports and administration. They're very robust reporting capabilities, putting information at your fingertips that you may have had to hunt for from multiple locations before. I'll touch on that briefly after I go through the portal itself. Now, I'm going to go to eligibility, and I'm going to run an eligibility for you and take it all the way to collecting the money from this patient. Now, these patients are real patients. We've changed their names to stay HIPAA compliant with written permission from them and the practices that provided them. We're going to real payers and in real time. Your patient would function exactly the same you're seeing here because these are real patients and transactions we're performing. Now, since the patient demographic is built in, we've loaded it, excuse me, you can search by patients through multiple criteria. If you're a high volume group, you're going to want to search by the social, the medical record, or account number, so you go right to that patient. You don't want to put in the name Smith and have 500 names come up for you to search for. I'm going to go ahead and search under the name. Well, we'll go with 4 characters within a name, and I'm going to let the system find it for me. And it found a patient that matches my criteria. That's the one I want. I click continue, and please notice that it has populated the patient information for me. Now again, this is skeleton data. We don't give you the real address or personal information about this patient, and the only thing your staff is asked to enter into this screen are 2 pieces of information, both in drop-down boxes. The first is the place of service. These are your places or departments. And the second is the rendering physician. In the hospital environment, this would be departments. Now, it doesn't matter what your system needs. We'll customize it to your needs. Excuse me. I'm going to show you there are 3 levels of eligibility. You are not required to go through all 3, but there will be instances where you may want to. You know, some of how you use the portal depends on whether you pre-schedule appointments for procedures and you know what's going to be happening in that meeting or that encounter, so you can do the estimate then, or do they have to see the clinician first, or do you have frequency patients, or do you have patients you see very rarely? A lot of that's going to be base how we recommend the best practice for you. So if I go into the first level of eligibility, I'm going to show you what we call base eligibility. Now that was 5 seconds or less. You now know that this is an eligible policy for this patient. That's all you know. Now in base eligibility, you may need it. You may need it if you're scheduling appointments, but you don't know what the procedure is going to be, but you want to ensure when you schedule the appointment prior to them showing up, they have an eligible policy so you don't have surprises on the day of the encounter. If you have frequency patients you're going to see 24 or 36 times over the next 2 or 3 months, we would suggest the best practice to you is to run base eligibility once a week to make sure that policy hasn't lapsed. You don't want to find out post-adjudication that you have to collect 100% of the last 6, 8, or 10 procedures because they either met their limit or they didn't pay their COBRA payment or they let the policy lapse by not paying their premium. Protect yourself. The second level of eligibility is what we call eligibility plus. Now in this screen, if there were a remaining deductible, it would appear here. All of the co-insurance information and co-payment information appears here, but we give you more on this level. We give you the ability to look at limits of liability with the click of a button. And if you need the full 271, all you have to do is click the button. We'll bring back the full 271 for you. And you will note these documents can be 30 to 120 pages long. So we literally hyperlink based on your specialty or your needs, what areas that you'd be interested in. So you could go right to that area if you have any questions or issues. Now, about half our patients use this 271, our practices and hospitals use this 271. Half of them never use it. I will tell you, if for any reason you get an error message up here, click on the 271. It's going to tell you the reason for the error. Now, there can be multiple reasons why there's an error. They could have a plan where they belong to a union and they have to, excuse me, have a certain number of hours to qualify, and they didn't qualify. So it comes back as either ineligible or an error. It'll tell you. If your data that you give us has typos in it, one of the things you're going to find out as a instant insurance eligibility tool is if there's a policy number typo, a date of birth typo, or the gender that you selected for this patient was inputted improperly, it's going to tell you there's an error. Click on the 271. It'll tell you why. You can edit that patient in the portal in 30 seconds or less and fix it forever. But the data is going to identify if there's errors in it immediately. The third level of eligibility is the estimate itself. Now, you could have gone directly to this estimate. And I want to stress, folks, eligibility for us is a means to identify what the patient owes so you can get the money secured. If you have eligibility in place that you're comfortable with and you prefer it and it's as efficient as ours, that's fine with us. You don't have to go through these eligibilities. You go right to securing your money in pre-authorized and automated payments. But since we're in the estimate now, I can go ahead and search for my procedures by either CPT code, 1 through 5 digits, DRG if we've loaded it that way, HCPCS or J codes, depending on what your qualifications and your requests are. Now, I put in 3 digits. It brings up all of the matching 992s for me. I'm going to go ahead and select several of these. Believe me, I know you would never select multiple 992s, but I'm going to do that for the sake of this demonstration. Each time I select one, it moves it over to the selected procedures. And I'll select one more. Also, you are not married to just one set of codes. You can go into another set and add those, which I'll go ahead and select a couple of these. You have the ability at this point to add modifiers to any one of the procedures if your people are trained to do so. Otherwise, we can create custom codes for your frequency patients or your bundled procedures, and then they just select that code and it prices accordingly. Next, we tell the system in-network or out-of-network. In this case, we'll say it's a out-of-network event, and since there's no deductible, we don't have to be concerned about that, and we get the estimate. Now, what you're going to see happen on this next screen is it's going to bring up the eligibility plus information, because if we went right to the estimate, you didn't see it to this point, where on the left-hand side of the screen, it shares with you everything you need to know. Over here, it is showing you the summary, total billable, allowed, what the insurance is going to pay, and what the patient is going to owe. And then you can actually view this online by procedure, where it shows you across and down the billed amount, the allowed amount, how the deductible, coinsurance, and copay apply. So we would train you and your staff to simply print this line item statement. It'll be customized with your information at the top. It shows what we just looked at on the screen, and we'll teach your folks to say, Ms. Linderman, the insurance is going to pay $595.98. You're going to owe $255.42. How do you want to handle that today? Ms. Linderman says, I can't afford this all at once. No problem. Can you afford $127.71? Yes. Can you pay the first one today? Yes. So we know what she's going to pay. But here's a key step. We ask her to sign this. She now agrees she owes this money. There's no longer an argument, and it eliminates the first reason why we have trouble getting paid. She now agrees she owes the money. We also add financial guarantor language into this, telling them there's third parties involved. If for any reason the third party doesn't pay what's anticipated, she agrees she owes the money, and furthermore gives us permission to charge the payment method selected. So we ask her to sign it. It's now time to schedule the payments. Now I have the ability here to collect it all at once or to schedule the payments, or if there's an odd number, let's say she agreed to pay $55.42 today and $50 a month, I could collect the $55 and then set up the $50 a month, but she's going to pay 2 payments, so I'll hit the schedule payment button, and you'll note it brings over the patient information. I'll go ahead and select the location of the service so the financials reconcile with the day of care and the location. She's going to pay $127.71, and she's going to make 2 payments, and she's agreed to pay it monthly. But here again is another best practice. If you have that frequency patient, you can collect your money weekly before you actually see the patient for those procedures. So let's say you're going to see them 3 times this week. You arrange the payment to be collected on Monday. Think of the advantages. You can tell your patient they don't have to check out at the end of the procedure. They can just leave. But from your perspective, you're prepaid. If they don't show up for a procedure, all you owe them is another appointment. You don't have to double book patients or triple book patients to ensure that you're not wasting time and have them sitting in the waiting room getting aggravated at you. But she's agreed to the month, so we're going to collect the first one today. And now remember, since the system is going to do this automatically, once I finish this process, I'm going to collect my money today. It's going to appear in my bank account, and then 30 days from today, it's going to collect the second $127.71 without the need to ever send a statement or an invoice, deal with a confusion call. The money will simply just appear. Now, we have multiple ways with which to collect the money. We can take a credit or debit card, and we can do that by swiping the card on the card readers that are attached to the computer or typing it in. We can take a check and either scan it if you have the scanners or need the scanners, or type in the routing and account number and turn it into an electronic funds transfer so you have your money within 24 hours, not having to wait for the check to clear for 3 to 5 days or as much as 2 weeks. Or we can have a payment method on file already captured for this patient. Now, in this case, what we suggest, payment method on file, the real world is this. You're never going to get 100% of your patients to opt into pre-authorized and automated payments or a payment method on file. We know this, and believe me, every single client we've ever put onto this portal went in thinking they'd never get their patients to pay at point of care, and we have a 90% success rate collecting this money when we ask for it. And the fact is, the whole industry is moving to this model. Everything you read, everything you see. In fact, governments are requiring you to inform, state governments are requiring you to inform patients what they're going to owe at point of care pre-service. And remember, pre-adjudication is the only way you're going to get this money secured. Now, since I have a payment method on file for this particular patient, I'll go ahead and I'll use a payment method. Now, here's a best practice policy we always recommend. If the patient says, I don't want to do pre-authorized or automated payments, you tell them that's fine. We're willing to put you on cyclical billing. However, it is our policy we have to have a payment method on file so that if any balance ever goes over 90 days, we reserve the right to charge that payment method. Remember, our job is to protect you financially. Now, there's a 98.3% success rate at collecting this money on these scheduled payments. Yes, you will have the occasional credit card where they ran up the charges too much, or it expired, or it declines, or you'll have the occasional bank account where they come back NSF. 98.3% of the time that won't happen, and the system has some tools built in to alert you and capture another payment method if necessary. So all I do is click continue. You'll see it's asking me, is this what you want to do? Yes. I print the agreement for the patient to sign. It spells out specifically, again, customized with your information. It spells out specifically what we're going to do, process 1 payment a month, a total of 2 payments beginning today of $127.71. Please note the financial information is secured. This is the legal language giving us permission to not only collect today, but the subsequent payments without further notice. We ask her to sign it. We click next, and it's done. It has just collected $127.71, going to deposit it into my bank account, and it's going to automatically collect the second, payment. Now, I stated that to do this and explain it makes it seem cumbersome, so I'm going to run through another one from eligibility to collection of the money, just so you see how fast this happens when your people are prepared and proficient. So I'll search for another patient. Yes, that's the one I want. I will pick my place of service, my rendering physician. I'll go right to my estimate. And that was about 7 seconds. I now know it's an eligible policy. I'll go ahead and add my CPT codes. I'll select several of these. And just for grins and giggles, I have to add one more code. Select the benefits based on, well, I guess I missed, no? Obviously, she's an out-of-network for Dr. Chapman, so, but you notice here there's a remaining deductible, so I want that to apply. Ms. Chrisman, the insurance company is going to pay $202.80. You're going to owe $852.20. How do you want to handle that today? Oh, I can't possibly pay that all at once. Can I pay payments? Well, yes. Can you afford $85.22, and can you pay the first one today? And if that's okay with your policies, then that's what we'll do. Yes, I'll print this, have her sign it, schedule the payment. Remember to tell what location she's being serviced at. $85.22, a total of 10 payments. And we want to start the first one today. And she has a payment method on file, so for ease of use, I'll just go ahead and use that. Print the agreement. Ask her to sign it. Click next, and I am done. I now have collected my $82, and then for the next 9 months, another $82 will automatically appear in my bank account without cyclical billing costs. Now, there's many other ways that you can use the payment screen. You can just collect money. You could use it by calling older patients and offer them the ability to pay in a comfortable monthly budgeted payment, have a empathetic healthcare script, which we can give you that basically says we're healthcare providers. There must be a reason you're not paying us, and it will instantly spike your cash flow because 50 or 60% of your existing AR patients will appreciate being able to put it into a normal budget. They're looking for a way to pay you, or they're afraid to tell you they can't. So there's several options available there. Just a couple of more quick things. The reporting, this is what we call the payment transaction report. I'm going to run this for today, and what you're about to see is every payment that's actually going to transact today on your behalf going into your bank. Now, you'll see the two we did, but many of these could be payments that were set up 2 months ago, 6 months ago, last week, for every week. These are the dollars that are actually going to transact and go into your bank account from whatever was scheduled for today's date. Now, what I want you to see here, which is very important, is the ability, if for any reason I have overcharged this patient, I simply click the refund icon. I tell the system I've made a mistake. I need to refund her $27.71, and it does it automatically with 2 mouse clicks, and I have just refunded her that $27.70. I could print her a receipt and mail it to her and avoid cutting a check, a cover letter, and all of the costs associated with the refund process. Also on this reporting capability, we will bring this report to you in an Excel spreadsheet with the click of a button, so that you now have the ability to manipulate and look at this data either by location, by department, by provider, and do forecasting and budgeting you probably haven't been able to do in one data silo before. We also will monitor who's doing the processing within the portal for you, so that you can either train them better, discipline them, or prevent fraud from anybody trying to do something they shouldn't. And this can be imported into your practice management or HIS system to upload and keep your accounting system fully up to date. Now, we have 3 ways we can communicate with your existing accounting program and practice management or HIS system. We can create a real-time interface, either HL7 inbound or outbound or XML. We prefer XML. A lot of the programs out there aren't ready to provide it. We don't like HL7 as much because it's not as flexible, but we can do it. Now, if you're not a high volume group, we don't recommend it. All right, there's cost involved, not only on our end, but your vendor will charge you to set it up, and you may have to buy add-ons. Like, for instance, Meditech has to have iAtrix attached to it, things of that nature. But it's not necessary because we're going to load 100% of your patients into the portal before you get started. The only patients that won't reside in there will be your new patients that come in, and it takes 30 seconds to a minute to add a new patient. But if your volume dictates it and you want the interface, it's there. Otherwise, we can use simple import, export, or if you had to take this report and sort it alphabetically at the end of the day and manually enter the payments into your accounting system, it's still faster than the way you're doing it today, because when a check comes in the mail, you have to open up the practice management system, search for the patient, enter the payment, and leave. And you do that 50 times during the course of a day. Whereas if you had the same 50 patients in a report in alphabetical order, you go into the program once, and in 20 minutes you could enter all of those patients. Okay, last couple of things on the portal itself. You have the ability to actually do cash flow budgeting based on the payments that are scheduled. I could go out for the next quarter, 6 months, and actually do a cash flow projection of what's anticipated at 98% confidence it's going to pay for either by department, by location, or as the company as a whole. And the estimates themselves stay in the portal in perpetuity, 7 years to stay HIPAA compliant. So I'm going to go ahead and search for some of the estimates we have just done. And in this case, I can open it, and I have the ability to look at it again. I would tell you some best practices based on having this available to you now, probably for the first time. I would give my super bill coders or my claim processors a username. I would have them look at the estimate we've given the patient and make sure it matches so you don't have a typo of a code and avoid claim denial. When the insurance company adjudicates, you should have a user go in and look at this and make sure they paid you what they were supposed to. 1 out of every 5 claims paid by the payer is paid short. That's a national statistic. California just sued 5 major payers because they continued to do it for 2 years after being warned, and they're suing them for $150 or $200 million because they've been shorting providers for 2 more years. Also, since this is real-time information from the real payer for a real patient, if the claim gets denied, you should have a more palatable time appealing the claim. Okay. So that's the portal, and there are obviously more that the portal does, but our time restricts us being able to go into detail about the administrative uses and how easy it is to function. What I do want to touch on is the why. Why do this? I know you are being bombarded with things you are being told you have to do. Moving from ICD-9 to ICD-10, upgrading or adding an EMR, and of course being penalized if you don't by 2014. New audit procedures for Medicaid and Medicare. All of these are telling you with the promise someday they're being mandated on you with the promise that someday they're going to make you more productive, more effective, more profitable. Okay, give them the benefit of the doubt, and maybe that's true. But there hasn't been a single EMR implementation that I know of that hasn't taken a year and cost twice as much or more than what was originally projected. When you factor in the ongoing training, errors, and mistakes while you're learning. ICD-9, ICD-10, everybody is finally realizing they're going to have to run both for at least a year, because any claim you have in process on ICD-9, you still have to have the tools to finish it in case it gets denied. And the audit procedures, you're having to hire new people or train new staff to manage those. The one area that you can impact that can have immediate effect on your bottom line is the amount of money you're collecting from patients, what they owe, and when you're collecting it. And this is the type of impact we're talking about. This is a real client of ours, and we do this type of analyses with every prospective client, and then we monitor to make sure we're meeting our goals. This is a 10-doctor group. I've obviously changed or taken out their name, but they do about $12 million in gross revenue. It's a smaller practice. They see about 25 now that's gross revenue is payer and patient revenue. They see about 25 patients each. Before us, they were only able to verify about 50% of their patients' eligibility pre-service just because of the cost and sheer volume. They were doing it the way most are, either a telephone call to the payer or a visit to a website that the payer promotes. They want to do 100%. It was taking them about 15 minutes average to do eligibility at a cost of about $3.50 per eligibility. One person can do 4 every 15 minutes in an hour, and they're paying that person $14 an hour. They bill patients roughly $300,000 in out-of-pocket billing monthly, and they were able to identify about 30% of it is going uncollected, either sitting in over 90-day or being sent to collection agencies. And that doesn't include the hard cost of cyclical billing. Remember, the national average for what we don't collect is 49%. So we took them for their word and assumed they were a little more efficient than the national average. They estimated it cost them about $9 when we did the analysis with them to send a statement, and they send about 3,000 statements out per month. The net impact we're having with this group is we are adding 1,085,152 additional net dollars per year to their bank account. Now, we're not going into someone's basement and printing this money. It's money they're due. They're either spending it now or they're not collecting it. So here's where those dollars come from. We're going to save them 62.5 hours a day on just the eligibility process. We average about 3,000 man-hours per practice on eligibility savings alone per doctor per year. And that doesn't include the hours of not having to send statements, not having to deal with confusion calls or begin collection activity. But on just this area alone, about 62.5 hours a day, saving them about $5,900 a month. If 3 out of 4 of their patients opt into the scheduled payments or a payment method on file, will reduce their billing costs by 65%, which saves them about $17,000 based on $9 a statement at 3,000 statements. And since they are not collecting about 90,000 of this 300,000 per their numbers, we will increase the amount of money collected by about $67,500, again, if we are 75% effective. This is the real reason it's time to make this change. What could you do with another $1 million or $100,000 or $30 million? We had a presentation with a medium-sized hospital today, and the impact for them was going to be $36 million more net cash. Okay, that is the presentation. I'm right on time. I will see if anybody has any questions. You can either type them in or raise your hand. I do see that. James, can you hear me okay? James? James, are you there? Okay. James, there must be something wrong with your microphone because you're not able to speak to me. Victoria, I see you have your hand raised, but I'm not sure if there's a reason for that. So type something in if you want me to open you up. Victoria is one of my managers. I don't see anybody has any questions typed in. If anyone does have any questions, please, I'll be happy to answer them. Otherwise, by all means, I'm sure you'll be hearing from the consultant that invited you. Otherwise, please reach out to them. We want to sit with you to do the specific analysis with you, not only the financial impact, but to talk about what you do today, what your staffing abilities are, your patient mixes, so that we can identify for you best practices based on using the portal. I impress upon you again, the time to sit on the sidelines to wait to make a decision on how to resolve this is over. Every day that you use the post-adjudication billing system is putting you further and further in either financial challenges, difficulties. We had a group that told us last Friday they laid off 6 people. We hear about groups where doctors are taking second jobs in ED departments. You are seeing a rash of physicians selling their practices to hospitals again. The reason is it's hard to make money. And one of the reasons it's hard to make money is because the patient pay has grown to be too much. If 50% of 30% of your money is not paying and you run on 7 to 12% margins, this one issue alone is putting you in the red. And we can resolve this with you, and we look forward to working with each and every one of you as a client, and we will work very hard for and with you. Thank you all very much. Have a wonderful afternoon, and we look forward to working with all of you.